IV lytics and what's the role of IV lytics in combination with mechanical thrombectomy. What you see there is almost as beautiful as the beach, but completely different. That's the mountain range in Switzerland where we are. The hospital is not too far away from this. And I'm going to talk about the IV lytics. These are my disclosures, might be less interesting. The only interesting part is I'm the global PI of 2 trials, and one is the important one right now, which is Swift Direct. With this we start. So what happened in 2014 was that randomized controlled trials have shown that IV lytics alone are not as good as IV lytics plus mechanical thrombectomy. So it basically set the stage for mechanical thrombectomy. But this is historically grown because IV lytics were around and then you had to apply mechanical thrombectomy on top. So since then, basically what we have, you have small peripheral occlusions and they are IV lytics only. You have those patients with proximal vessel occlusions within the time window of IV lytics, and you apply IV lytics and then go for mechanical thrombectomy. And beyond that, you go for mechanical thrombectomy. So this is basically the gold stage today. What do you know about IV lytics? So systemic thrombolysis. There is a peculiar finding, if you look at the meta-analysis of this, that the effect of IV lytics disappear over time. So after a certain time, the confidence interval of 1 is crossed. So that's why IV lytics are not applied beyond the time window of 5 hours. The effect is time dependent with systemic lytics, and that's quite surprising. The second one is that in these meta-analyses, if you have a patient with a low NIHSS score, the chances of recovery is much higher than with high NIHSS scores, which is a bit surprising because we're treating a thrombus, not an NIHSS score. So where's the combination between IV lytics are very effective with low scores and less with high scores? And probably the solution is, and this has been shown in a study, that if you have a very small thrombus, like in a peripheral vessel, the chance of recanalization with IV lytic is very high. And if you have a large thrombus, the chance is very low. And this led to the hypothesis of the last years that IV lytics are very good if you have small thrombi, distal occlusions. At the same time, it might not be very effective in proximal occlusions, which then led to the idea, do we need lytics at all if a patient with a large occlusion comes to your hospital? So should we get IV lytics, yes or no? So this could be the new paradigm: peripheral occlusions, IV lytics; proximal occlusions, only mechanical thrombectomy. And obviously there are always pros and cons. So applying lytics might lead to clinical improvement, might lead to better recanalization. At the same time, it might also cause bleedings. And always we have to keep in mind, in every country, it's expensive. So you pay some hundreds or thousands on the IV lytics. So the cost effectiveness plays a role. If we want to investigate the role of IV lytics in large vessel occlusions, then there are 2 patients populations, and it's important to understand that we keep them apart. One patient population is the drip and chip patients. So they come outside, they go to a stroke center far away outside Da Nang. They get IV lytics. And then with IV lytics, they go to the stroke center and receive mechanical thrombectomy. And I'm not going to talk about those because they have been randomized in another trial like RaceCat. So this is a different animal because lytics have long time to act on the thrombus because they have time. And the one that I'm going to talk about is those who come directly to your center. If you work in a comprehensive stroke center, they go directly to your center, and you have to decide whether you would like to give IV lytics, yes or no. Patient comes to the center, receives IV lytics, then goes for mechanical thrombectomy or is randomized towards direct mechanical thrombectomy. And in this setting, there have been a couple of trials in the last 2 years. Total 6 randomized controlled trials trying to find out the role of IV lytics in mechanical thrombectomy. They wanted to show that direct mechanical thrombectomy is as good as IV lytics plus mechanical thrombectomy. And while these trials were running, all the PIs agreed already that we're going to pool the data. So now, today, I'm going to talk about the pooled data. So I'm together with Urs Fischer organizing the Swift Direct trial in Switzerland or Europe and Canada. And you see all the different PIs, and we all agreed we're going to pool. And what you see today is part of the pooling result. And we can pool these trials because they were so similar. You see that The enrollment criteria are not too different. Basically, the occlusion pattern is the anti-circulation. It's distributed in the world, so you have Asian population, you have European population. Vietnam was involved as well, actually, in direct safe. And also the amount of IV lytics that have been given are comparable. So we can pool this data. So 6 trials, or put all the data together on an individual analysis and see what is the effect of IV lytics or direct mechanical thrombectomy. Again, mothership patients. So patients came directly to the center, and there the randomization took place. So the aim was to find out if direct mechanical thrombectomy is non-inferior or superior to the bridging concept, IV lytics plus mechanical thrombectomy. And what I'm presenting right now is already in print, so we are going to expect that the publication is accepted, so you can read all this within this month. Now, what is non-inferiority? Why should one treatment be non-inferior? What's the boundary when you would say both are the same? And that's actually up to you and me. Physicians have to decide what is non-inferior. So we did a survey to ask, what would you expect as a non-inferiority margin? And the majority was 5%. If 2 treatments have the same, have a 5% difference, then we would still say there's non-inferiority. And this converts then statistically in a non-inferiority boundary of 0.82. That's what you see there. So it's 5% or confidence interval not crossing the 0.82. This leads us to the result of this first batch that I would like to show. So if you look at the basic characteristics, first of all, now lots of patients for stroke studies. So 2,200, 300 patients, so 1,100 on each arm. And you don't see a huge difference in age. You don't see a huge difference between direct mechanical thrombectomy and bridging thrombolysis according to the NHSS and to the aspect. So we can say whatever the result is, most likely those groups are well balanced. It's not a completely overdriven trial. Few patients had to be excluded. So now we come to results. So if you apply bridging thrombolysis or direct mechanical thrombectomy, does it change the outcome in the modified ranking scale? And surprisingly, it does not really a lot. So if you look at direct mechanical thrombectomy, 1,151 patients, and the bridging concept, there's literally no great difference in the shift. So IV lytics, whatever IV lytics does, it does not cause a huge effect. That's interesting. But at the same time, we did not meet our non-inferiority margin. So statistically, we cannot say that IV lytics or direct mechanical thrombectomy is non-inferior to the bridging concept. At the same time, we can look at all this different data. So the functional independence, 2% difference. It's not a lot if you invest in IV lytics. Nevertheless, there is an effect. Successful reperfusion, yes, it's a little bit higher, but not tremendously higher. You apply an additional drug. And if you look at the early recanalization, so before mechanical thrombectomy, actually IV lytics in the mothership concept does not help you very much to recanalize. Which means, if you look at the modified ranking scale, we have a study which is unable to prove non-inferiority for direct mechanical thrombectomy. At the same time, it's also unable to prove superiority for IV lytics. I'll come to that in a second. This means this is inconclusive. So after 2,300 patients, we cannot say whether it's superior or non-inferior. That's quite a sobering result, I would say. So now if you look at the different subgroups, any kind of hemorrhage, it's a bit more likely or less likely to have a hemorrhage, any kind of hemorrhage if you don't apply a drug. So direct mechanical thrombectomy is in favor not to cause hemorrhages. And the same accounts for symptomatic intracranial hemorrhages. The mortality, both arms are pretty much the same. Successful reperfusion, we actually see a signal. So IV lytics help to reperfuse, but the overall shift, again, is only 2% in outcome. Aspect score, there's a tendency that patients with low aspect score benefit from direct mechanical thrombectomy. And then this is interesting because if you look at the different time window when patient received IV lytics after onset, you see a shift there. And we're definitely going to go into this in the last 2 minutes of the talk, because that's probably the most important part. So in conclusion, if you pool all the data and look at all these patients, direct EVT is not non-inferior to the bridging concept at this margin of 5%. At the same time, IVT cannot prove superiority as well, so it's indifferent. There is an effect of IV thrombolytics, so you have a high recanalization rate at the cost of higher hemorrhage rates. And the benefit of IV lytics is very small. It's about 2%. So you apply lytics in your mothership concept, you get 2% higher recanalization rates. That's really not a lot. If you would calculate the number needed to harm, so if you would leave it out, you don't treat with IV lytics, the number needed to harm would be 57. So if you don't give IV lytics in 57 patients, you have one worse outcome. So that's a high number. And that's important, it seems as if the effect of IV lytics is diminishing over time. But this will be what I'm going to look at. What does that clinically mean to this point? To this point, it means the effect is low. The question is, do you really want to apply it, because it's not very cost effective? If you compare IV lytics, the difference is 2%, but mechanic thrombectomy in hernias is 20%, which means mechanic thrombectomy, anterior circulation, mothership patient is the backbone of treatment. So whatever you do, mechanic thrombectomy is the one to go, and IV lytics don't have a huge effect on it. And probably the most important one is, if you apply IV lytics, it should not delay or prohibit endovascular treatment. This to this point. The last point is something that will be discussed most likely quite intensively in the future. We just presented it, but it's probably very interesting for you to see. Now we have an inconclusive result. It's not superior, it's not inferior, it's somewhere in between. Now we know from IV lytics that the IV effect diminishes over time. You might know this curve from the meta-analysis. And we have some sort of a signal in our trial as well. So we looked very much into detail whether the IV effect is probably time dependent as well in a bridging concept. And all my credits to this guy here, who did all the work, Johannes Käsmacher, and it's this publication is under review currently. So the question is, IV lytics is that time-dependent effect when applied in a bridging concept. Now, if you do this statistically, the problem is half of the population received lytics, half of the patient went directly to mechanic thrombectomy. So what we had to do, we had to calculate the estimate time until between onset to IV lytics. And this has been done. So we took all the trials, we looked at all the data, and then we computed the overall time. And this leads us to the result, and that might be quite striking for you now, because if IV lytics after onset of symptoms is applied within 2 hours and 50 minutes, then there's a definite shift. So you see that mechanic thrombectomy alone is definitely inferior to the bridging concept. 2 hours, 50 minutes, IV lytics is highly effective. Beyond that point, we see the same, it's not very effective anymore. So there is a time-dependent effect, and IV lytics should be applied within 2 hours, 50 minutes. Beyond that time point, it's very questionable what the result might be. Now, if you look at this, and this is now from the superiority, this means within these 2 hours, 50 minutes, IV lytics is superior to mechanic thrombectomy alone, and after that, there's no great effect anymore. And you probably understand this will have major discussions for guidelines in the future, because that would mean a patient comes into the hospital 2 hours after onset, 2.5 hours after onset, and you don't apply lytics anymore. So that is, I think, a very, very interesting result. And you can calculate the number needed to treat as well, and you can see within these 2 hours, the number needed to treat is low, and then it shoots up. So IV lytics are not effective anymore. We don't know why, but it's definitely the case, and it's absolutely in parallel for what we see for IV lytics, systemic lytics without mechanic thrombectomy as well. Now, the last question remaining, is that relevant? So do we see patients within this time window of 2 hours, 3 hours, 4 hours if we all see patients within half an hour, then this whole study is not worthless. Is worthless because you treat every patient. If you would see every patient beyond 3 hours, it doesn't make any difference as well. So if you look at trials, is that time window relevant or not? And we looked at different studies. So Hermes was all of the patients have been randomized within. Large German study, it's right in the center, so it would have made a major difference for those patients. Probably half would have received IV, the other half not. RaceCat, probably many of them would not have received IV. Mr. Clean was in a very good time window. Stratis, large registry, some patients would not have, and there's a large Chinese trial as well. And in this, you see it's pretty much in the sense. So it is clinically relevant. These 2 hours, 50 minutes might be the way to go in the future. With this, I would like to summarize and finish. So the effect of IV lytics is time dependent. It's in systemically time dependent. It's also time dependent in mechanical thrombectomy. We don't know why, but this is a very clear effect. And this should be taken into account when applying the drug. So beyond the time window of 2 hours, 50 minutes, probably quite questionable in the future whether you would like to invest the money and the time to apply the drug. And in the end, superiority, and that's probably the most important one, the superiority is now proven. So within 2 hours, 50 minutes, there's a superiority of the bridging concept. And beyond that, there's no superiority anymore. Actually, there's no effect anymore. The number you treat goes up. That's what I want to show. So you see the overall picture of IV lytics and then a very detailed picture on the time window. And from my point of view, this is probably the most important finding of these 2,300 patients. And I'm very much looking forward to how this will be incorporated in the guidelines. With that, thank you very much. I think will be a lot of questions.
The first question from Professor Tung.
I would like to ask your opinion about this conclusion. That means that if you see the patient over 2 hours and 50 minutes and you go directly to mechanical thrombectomy, yeah.
Right now, the guidelines say something different. The guidelines still say every patient who is eligible for IV receives IV. From my point of view, and this is what's happening in our hospital, we don't give it anymore beyond this time window. So I think this will be a very intense discussion because this would completely change the indication for IV lytics. At the same time, it's highly relevant because we all have to look for cost effectiveness in every society, in every health system, and this is definitely a contribution to cost effectiveness of a drug.
And my most concerning is how do you detect the small vessel and large vessel? Or you use CT scan for screening or MRI? Mm-hmm. Because it's very important. We saw that with the MRI screening, when we know small vessel, just IVR TBA, large vessel, thrombectomy.
Yeah, spotting a large vessel occlusion is usually much easier than spotting a small vessel, as always in life. For large vessel occlusion, a CTA or MRI usually shows you the stump of carotid T or the stump of M1. For small vessel, meaning M2, M3, M4, what is very, very helpful is perfusion scans. If you have the chance to do a perfusion scan, CT perfusion, MR perfusion, very, very helpful. It's a detection tool to find these distal occlusions that you don't spot in the angio. You have to follow all these branches and you can easily miss a branch or a stump of a branch. In perfusion, almost impossible to miss, but it gives you the explanation why the patient has a neurological symptom and gives you the justification to treat the patient. So if there is a chance to have CT perfusion or MR perfusion, very helpful for small vessel occlusions.
Any more question? Because we don't care about the time, so keep going for question for interaction section, more successful. Yes.
Thank you for a very nice lecture. Two quick questions for you. One is that what if you had changed the decision of 5% being important? What was it, 10% or 15%? How would it change the results? Secondly, and maybe I missed it, the onset to groin puncture time, was it different in the two groups? Would that made it an impact on the results? Thank you.
First of all, this is the old discussion of what is non-inferior. You find trials in which non-inferiority would be 15%. If it would be 50%, we would have proven non-inferiority in this trial. Why did we choose 15%? Simply because this is what you all said. We sent out surveys and the answer was 5. It's much easier to prove something with 15, but that's the way it is. It is pre-specified. And the second question, just shortly. No, it's not. The onset to groin puncture and also the onset to randomization is not different between the groups, but it's different within the studies. So studies, 6 randomized controlled studies had different time windows, but we correlated this, or we corrected the results that you see here, that this is not a result of one study driving the whole thing different. But within the studies, it's completely different. Within the study groups, it's the same, or the arms.
I would like to add one comment because for the neuro intervention, actually we scare about the IV-RTBA and then thrombectomy. We really scare about that. Because in case of Asian population, we have a lot of intracranial stenosis. I show you last talk. And in situation when we need to combine like antiplatelets to put emergency stent, it's very dangerous because increase the risk of bleeding for the patient because just IV-RTBA and antiplatelet combined together. So we scare about that. So in case suitable for IV-RTBA, so for a small vessel, it's preferable. If we try to combine everything, IV-RTBA and send to thrombectomy, it's more dangerous in our vision. What about you think about that?
Absolutely. First of all, we don't see that many intracranial stenosis. The frequency is much less, and mainly in the posterior circulation, not in the anterior circulation. A similar setting is carotid artery stenosis, tandem lesions, in which we run into the same situation. You have to decide whether you would like to place a stent. If you place a stent, then you're obliged to use aspirin, Plavix, or whatever, and then things become more complicated. Probably just as one side branch, we didn't look into the different genetic backgrounds in the study yet. We're going to have a look at this, but we have seen that using IV or not using IV didn't make a difference for tandem lesions yet. So, but absolutely well taken. Very tricky to have too many drugs on board. You have a stroke, which can bleed. Then you have IV-lytics, and then you have aspirin, you have Plavix, and you probably put some heparin, and then the patient at one point must bleed.